Bom dia a todos, buenos dias, good morning. Primeiramente, eu vou pedir desculpa para os nossos, quem está assistindo aí à distância, mas infelizmente, também quem está presencial, eu não vou conseguir falar em português e inglês, como o Nathan falou, porque eu vou ter um desafio grande aqui de resumir um tema que é extenso em pouco tempo. Então, eu vou falar em inglês, mas quem tiver dúvidas no final eu posso responder em português e a gente pode conversar depois, trocar e-mails, tá bom? So this slide is much similar to the slide Maui presented before. The causes of death in Brazil are very similar. The main ones, the Chinese situation. So cardiovascular disease are the main cause of death. It was like that in 1990s and still the situation right now. Nathan presented about the primary health the primary care in Brazil and the family health strategy. I just want to highlight some challenges the family health strategy still faces in Brazil: underfunding, insufficient infrastructure, the availability of doctors in remote regions is still a challenge nowadays. This program, Mais Médicos, More Doctors, aims to bring these doctors to these areas, but sometimes they stay for a short period of time and there is a rotation of physicians all the time. Tem those labor ties between professions, institutions, employers, access to exams and specialized care, and training of professions that's not aligned with the primary care centered healthcare model, and need of continued education. So Telehealth in Brazil was implemented to support family health strategy, mainly to improve access to specialized healthcare and exams, and to help with continued education. So Minas Gerais is a state with a lot of disparities. It's a large state in an area bigger than Spain, more than 21 million inhabitants, 853 cities, and most of the cities are small. 93% of them has lower than 50,000 people. So the telehealth network of Minas Gerais was implemented in 2005 as a research project in small cities, 82 cities, with a very low human development index with the ECG report. Why ECG report? Because cardiovascular disease was the main cause of death, and it was a study was performed in the area, and it was observed that the access to ECG report as a very simple exam was not available in the small cities. In that time, a partnership between 5 public universities was formed to perform this research project, and it was very successful to improve the access to ECG, and it was very the cost benefit showed that the strategy could be implemented to other cities with a very good cost benefit. After that, the state of government in Minas Gerais decided to support the telehealth network and implement in other cities. It was progressively implemented in more and more cities, and nowadays it attends 814 cities in Minas Gerais. It's now formed by 7 public universities of Minas Gerais. And as the service expanded and got more specialized, not only in ECG reports but all other services, the Ministry of Health also decided to invest in the service, and now it currently assists cities of 5 other provinces in the country. For these provinces, only for ECG report, in total 109 cities in 5 different states, all of them very poor cities in these states. Nowadays, the financial supports include the government support, Ministry of Health, State Department, and Municipal Department of Belo Horizonte. research funding agencies, and also charges and private contracts. The activities include the teleassistance, the clinical support, telediagnosis, ECG, fundoscopy, Holter, echo, teleconsultations, mobile health. Teleeducation is an area that's currently expanding in our service. Online lectures and courses, frequently asked questions, digital books and games, research, different kinds of research, implementation research, epidemiology and public health, big data and machine learning, and also support services. So how the telecardiology works? There are 3 to 5 cardiologists working on duty per day. The emergencies are analyzed in less than 10 minutes, and the routine exams analyzed in the same days. Nowadays, it's a 24/7 service, so the patients who need an ECG that's an emergency in a small city and it's at night or on the weekend, the physicians, the professionals also have the support of the cardiologist to analyze the exam and to discuss the clinical cases. So the software for the ECG was developed in-house. It's a web-based service, and the ECG reports are subject to periodic audits. The teleophthalmology started as a research project as well to assess the cost-benefit of the strategy, and it was very successful. The technicians in the smaller cities are trained to acquire the images, and we developed a system to transmit these images, and the ophthalmologists stay in the telehealth center analyzing the images and giving the reports. The reports are also subject to periodic audits. The teleconsultations, a second opinion, most of them are asynchronous, so the healthcare practitioner has a doubt in the primary care center about the clinical case or a general doubt, and he writes the doubt in a platform in our web site and sends the doubt about the clinical case and exams and all the information he has to our teleconsultation specialist. There is a gatekeeper who works on duty during the day to answer the most number of the teleconsultation, the most number of the doubts. So family health physicians, nurses, dentists, and audiologists, dermatologists, the areas that are most, that have the most queries, have the specialists on duty. If the specialist on duty can't answer the teleconsultation, it can be forwarded to a subspecialist. The specialist on duty answers the same day, and the subspecialist in 2 days. Some teleconsultations are special direct, mostly the infectious diseases one, and in cardiology there are also synchronous teleconsultations. There is another kind of teleconsultation, the teleregulation, to help to organize the waiting list for certain specialists. These are our main results, so more than 4 million electrocardiograms already analyzed, more than 129,000 teleconsultations, almost 4,000 Holters and ambulatory blood pressure monitoring, almost 5,000 fundoscopy, and almost 20,000 screening echo studies. Teleeducation is a field that we are growing and growing, that is very important to support the primary care practitioners. 22 courses were already developed, more than 70 online lectures, folders, digital books, and frequently asked questions, more than 100, and we had almost 1.5 million views in our YouTube channel. More than 8,005 professionals were trained. And one aspect that we're always worried about is to be economic smart. Like we have to save money to show the government that our activity saves money and provides a good service. So we monthly monitor the economic indicators. So our return of investment is 5.4 per real spent. Just briefly about the CODE study, the clinical outcomes in digital electrocardiography. We have this huge ECG database, and we can use it for epidemiology studies, but we are also working in machine learning and survival analysis, linking this with mortality and hospital data. There was a big study about atrial fibrillation mortality that we linked our ECG database with mortality data. Is a very interesting study. And now we are also working in machine learning to analyze automatically the ECG and comparing to physician analysis and medical students analysis. In this study, so the machine learning analysis, deep neurology analysis, was compared to fourth-year cardiology medical residents to emergency medical residents and also medical students, and the automatic analysis was comparable to the cardiology residents and better than the medical students and emergency physician analysis for the 6 abnormalities. First degree AV block, right bundle branch block, left bundle branch block, sinus bradycardia, atrial fibrillation, and sinus tachycardia. So the perspectives are broad, a better understanding of the prognostic value of ECG abnormalities, new markers of prognosis, full automatic classification of the standard 12-lead ECG, and to improve access of populations from remote regions to cardiovascular care. Because we started with ECG, but there is a potential to include other exams. ProVAR study, briefly, we trained technicians to acquire echo images, and we developed a system to transmit these images to be analyzed in our center. We started as a research project for screening of valve disease. Here in Brazil, we still have rheumatic valve disease. It's caused by bacteria. I don't know if you know about it. Caused by bacteria, sore throat. It's not well treated in regions that are poor or have not so are not well educated, or access to healthcare is not so good. So the kid is not treated, and it can develop a valve disease as a still common cause of heart failure in Brazil. So it started as a research project for screening for this valve disease, and it was shown to improve the access of these kids, and it's a cost-benefit strategy, and there were many publications about it, and now we are currently working to check a model to use it in primary care for this valve heart screening. Also not only for valve heart, but also for Chagas diseases. We start working research project doing this echo screening in the primary care, and to be analyzed by our cardiologists in the center. And implementation research, which is our main focus today, screening and control of hypertension diabetes in primary care in Mucuri Valley. It started as a project sponsored by the Medtronic Foundation. Mucuri Valley was chosen by the Minister of Health because it's a very poor area with restricted access to healthcare as a resource-constrained area. It was a multifaceted and multidisciplinary approach to NCDs, a collaborative action of academic institutions, health authorities, health professional team, and community. And this program is fully integrated with the public healthcare system in a way that it can be reproduced in other places in Brazil and also be sustainable even after research project finishes. So the Mucuri Valley is in Teoflotone micro area. 10 cities were selected, including Teoflotone, that's the most important city in the region. It's the only city that's more than 20,000 inhabitants. So the cities had to be this Human Development Index lower than 0.6, and the target population was 30 to 69 years of age. These were the 10 selected cities. You can see that all of them were very small, and the larger one had 13,000 inhabitants and low Human Development Index. So all the cities together combined had 113,000 inhabitants, and the target population was composed by 43,000 persons with this age. The needs assessment was performed before we started the research project. It was performed, sponsored by Medtronic Foundation. They hired another institution to do this needs assessment. That was very important to help with our ideas how to improve the situation. It included secondary data and also technical dialogues, workshops and focus groups with participants from the government, from the community, from physicians and professors, nurses, nutritionists, specialists, to discuss barriers and access opportunities and priority areas for improvement. These are the main barriers, in areas for improvement, they came in this final document. So the intervention overview. So it's a multifaceted and multidisciplinary approach. It included innovative and unique telehealth solutions to support of primary care professionals, including decision support system, telediagnosis, teleconsultations, and everything that we developed before helped us to put together and implement this in Mucuri Valley. And also for patients and educational text messaging. Training of frontline health workers, strengthening of educational groups, digitalization of primary care. In all these cities, the electronic health records were not used. All of them were paper-based. Improvement of access to exams. Everything in a collaborative action of academic institutions, health professional team, and community. So for the educational groups, we work in strengthening the educational group that already existed in the communities. So Hypertension, hypertension, diabetes, obesity, smoking, and physical activity. For the physical activity one physical educator from the team, the local team, developed these adapted functional trainings, and he trained other people to do the same. And it was very interesting and very well accepted. They used cheap material and could improve the way the group worked. And also, other educational groups were implemented, like storytelling, balance groups, and groups to help the patients to manage their own medications. The information technology was a main source to help to bring the evidence-based medicine to the communities. So we used different tools, telediagnosis, teleconsultations, clinical decision support system, education, SMS for patients, and point of care clinical hemoglobin that was a sub-project of this project, and teleeducation. In total, 7 hours and 30 minutes of course were produced. Of course, the courses were directed to a special, to each professional. And about the computer decision support system, the way we develop it, so started to develop validation, field study, usability assessment, and clinical impact assessment. So the computer decision support system was a tool to bring the evidence-based medicine to this community. So it provides a personalized evidence according to what the professional writes down the patient has. So it has a specific message for that patient. So how we develop that? First, we summarize the most relevant recommendations for screening and management of hypertension and diabetes. We developed the alert messages and also the decision algorithm. We had previous experiences for hypertension, diabetes, computer decision support systems. It helped a lot for this one. The validation comprehended pre-test and expert panel assessment. And just to give an idea, this was the screening decision support algorithm. It was based in the American Diabetes Association and Minister of Health recommendations. Then the screening software, and one screen for questionnaire, another one for the management, and then after filling out all these fields, there were the message saying if the patient should continue in screening or if the patient could just have an orientation about what to do, and, like, for example, eat health diet or physical activity. And there were two different screening activities. The health fairs, the health fairs were a big event with educational lectures for the patients, cultural events. Sometimes if there was a band in the city, the band played there for the community to participate, and also the screening activity with all these steps, the questionnaire, measurements, and the decision. And also door-to-door visit from the community health agents. For the patient management, so we built this software, it's a system. It includes symptoms, medical history, physical examination, medications, and exams. So we developed the decision algorithm, and the input combined with the decision algorithm generates the output, the recommendations, alerts, and reminders, and everything is stored in a database that we use to monitor the project. The system also provides the cardiovascular risk according to the Framingham score and the estimated glomerular filtration rate. So this is the computer decision support system screen with all the alerts and recommendations according to a specific patient. And if the professional wants to know further information about one specific message, he can click in this Mais Informações, that is further information, and it also contains the reference for that alert message. We assessed the feasibility, usability, and satisfaction with the decision support system at 3 months, and also the satisfaction with the project 6 months, and the results were always good. They were very satisfied with the project, with the decision support system. They could see that they could provide a better care for the patient using the decision support system. And we also made open-ended questions, and they told us that the main benefits of the project at that time were the education activities, the decision support system, the improved access to exams. They could tell that this project was helping to strengthen educational groups and the family health strategy itself. And they could tell that so far the project could improve the care for patients with hypertension and diabetes, and even improve the quality of care in general, because it was for hypertension and diabetes, but they could see that they had to improve for other diseases as well. And at that point of time, they already wanted the project to last for longer, because we had 1 year window to finish the project, but they could see that the patients could benefit for the project to last longer and to expand for the whole region and other diseases and a broader age range. In brief, the results for screening hypertension, although 9,000 patients were registered in the software, 2/3 of the patients had a previous diagnosis, so 3,000 patients were screened for hypertension. Of these, 77% were screened negative. There were 109 new cases, and there were 500 patients lost to follow-up. For diabetes, 12,000 patients were registered. 1,500 had previous diagnosis, so 10,000 patients were screened for diabetes. Of those, 61% were screened negative. There were 40 new cases. This information for me is very shocking because it's like 0.04%, and we had 38% lost to follow-up. So this slide shows how the criteria to screen for diabetes is very sensitive, but it lacks specificity. So after we could monitor the activity of the project, and we could see that there was such a low number of new cases, we could notice that it was better to focus the activity of the project in the patient management, not screening. We are currently working in the cost-benefit assessment of the screening, but we already can tell that the cost to diagnose just one case was very high. So in total, almost 20,000 patients were recruited, and 4,000 patients are monitored. We could reach 46% of the target population, and there were more than 8,000 consultations. Of the patients with hypertension, 3,900 patients monitored. Unfortunately, part of those have only one measurement of blood pressure, and 800 of them no blood pressure measurement in the system. We believe that the patients do have blood pressure management, but it was not registered in the system. So we could access 1,600 patients with at least 2 blood pressure measurements, and we could see from this follow-up time that the number of patients with controlled high blood pressure levels increased. Unfortunately, it's still low, but we want to increase as the project keeps going on. With diabetes, it's the same, 1,000 patients. Unfortunately, 400 of them with no glycohemoglobin measurements, although the project is providing exam. We believe that sometimes the problem is that the patients live in rural areas, more than 30 kilometers from the primary care center. In some cases, they can reach the primary care center only by horse, no car and nothing. So sometimes it's very difficult for the patient. That's why we are working in this sub-project to assess the usability and of the point of care glycohemoglobin assessment, and we believe that it's going to help to improve access for these patients. 200 of them only one measurement, so 400 of them with at least 2 measurements, and we could observe that there was an increase of patients with glycohemoglobin levels under control. We can also mention other results. The integration about health professionals, universities, and communities. This picture shows medical students helping with the screening activities, the multi-professional approach of patients, the rational access to complementary exams, the use of the computer decision support system as an important tool for healthcare to bring the evidence-based medicine for them, and the qualified the primary care with this. And it's important to mention for those who don't know about the computer decision support system, it's very easy for us to update the message. So if there is new guidelines, new evidence, we can update, and this new evidence will be there at primary care very fast, much faster than it would be without it. The digital inclusion, even the community health workers are using tablets. They use tablets to register the patients and to perform the screening activities. The opportunity for in-person and distance training, the improvement of self-esteem and a sense of professional appreciation. The professionals gave us this feedback. And we have this We didn't measure that, but we have this from what we learned, we heard from the professions, improvement of the quality of service provided. As success factors, I could mention the fact that the program is fully inserted in the public healthcare in SUS, the fact that it's multifaceted in multidisciplinary intervention, and the fact that it optimizes the existing structure coupled with innovative solutions. This partnership between universities is very important as well, and also the collaborative action by the government, academia, professionals and patients. If involvement of the state government since the beginning and the Ministry of Health since the beginning as partners. The project is not ours, the project is not from Mucurival, the project is from all of us. And this is important for sustainability. And the involvement of health professionals and patients as well. As challenges, the economical, educational and social cultural barriers. It's an extremely poor region in flow education. Around 40% of patients can't read, so the SMS intervention was not for all of them, was for just a selective group. The long distances, the unpaved roads that impair the access to the patients to the exams, lack of options for healthy leisure, political changes, elections, new mayors, health secretaries. Elections are always a big problem to sustainability of health interventions in Brazil. Every time that there is a new election, usually if the mayor is from another political party, all the team changes. So it's difficult to maintain. We have to retrain everyone and start over. Limited governability over some factors, for example, to drugs. Sometimes different drug is not bought from the government. Transportation of patients. To ensure internet access in all primary care centers. To improve usability of the computer decision support system. Now the Ministry of Health has implemented ESUS, the electronic health record. So the professionals have to register the consultations in ESUS. We have to work to have interoperability, otherwise the professional won't use both platforms. And to involve health professionals in the improvements of the system. Recently we worked in focus groups with them. They were very happy to give ideas and what they think we should improve. And it was a very constructive experience. To motivate primary care teams to follow this consultation model. Sometimes the physicians want to perform the consultation in 10 minutes, and sometimes if the system takes 20 minutes, half an hour, for them it's a lot because they have a high demand of consultations. Access to secondary care is still challenging. And fidelity assessment, we still have to work on that. It's a very important thing to assess in implementation research. So we have to work on that. There are consultations not using the system, and we also have to work to check adherence to decision support system recommendations. There are perspectives, so the Mediterranean Foundation funding is over now, but the Ministry of Health funded the project for the next 2 years. That was very good. We also are planning to implement the project in other regions and to include other conditions, Chagas disease, heart failure, anticoagulation control, and we also plan to conduct a cluster randomized control trial. So now HealthRise is changed to Charming, control of hypertension diabetes in Minas Gerais. So this is our idea to first to improve the model we implemented, and then test it in a cluster randomized control trial to validate in another population, in another study before and after in quality studies, and then to expand to other regions. So this is part of our team. Actually, our team is much bigger than this one. Wouldn't fit in the picture here in this slide. We can't work hard like that without a qualified and a motivated team like we have. We are happy to have a motivated team. And that's it. Thank you very much for your attention. I'll be happy to answer any questions. Obrigada a todos, obrigada para quem está assistindo também.